Welcome to another deep dive. Today we're exploring a health challenge that's, well, it's growing at an alarming rate globally. Non-alcoholic fatty liver disease, or NAFLD, in its more serious form, non-alcoholic steatohepatitis, NASH.
That's right.
What's truly fascinating, and frankly concerning, is its surprising sort of twofold impact on one of the most critical life-saving procedures we have. Liver transplantation. We've taken your sources, everything from large-scale global studies to detailed transplant data, meta-analyses, and really distilled them down to give you the essential insights.
And that distillation is crucial, I think, because this isn't just about understanding a single disease, is it? It's about a complex interplay. You've got these major public health trends, the increasing scarcity of donor organs, and then the long-term care needed after a transplant.
Right.
Grasping this connection is absolutely key, I feel, to understanding some of the most significant challenges healthcare is going to face in the coming decades.
So, okay, let's unpack this. When we talk about NAFLD, the sheer scale, I mean, the numbers alone are staggering, aren't they?
They really are.
It's rapidly become the most common chronic liver condition worldwide, and it's largely fueled by these, well, epidemics of obesity and type 2 diabetes that we see everywhere.
Exactly. The drivers are clear.
The statistics really jump out. Recent meta-analyses estimate that around 30, maybe 32% of adults globally now have NAFLD.
Yeah, roughly a third.
And if we break that down, it's closer to 40% of males and about 26% of females. Huge numbers.
It's a massive number, and it's important to clarify the distinction here, like you mentioned. NAFLD is essentially simple fatty liver fat buildup, but without significant inflammation or damage yet.
Okay.
But NASH is when that fat goes further. It actually causes inflammation and liver cell injury.
That's the dangerous one.
That's the one we worry more about progressing. Now, the concerning part, while not everyone with NAFLD progresses, about 15 to 20% of those patients do develop a NASH.
Okay, so a subset.
A significant subset, yeah. It works out to roughly 3 to 5% of the general population having NASH. And the prevalence has really spiked. For instance, studies show it jumped from, about 26% pre-2005 to around 38% after 2016.
Wow, that's a quick rise. And looking ahead, what do the projections say? How much worse could this get?
Well, the predictions are quite stark, honestly. Another 21% increase is predicted by 2030.
21%.
Which could mean over 100 million cases globally. And this isn't just an abstract number, it has very real and often devastating consequences.
Like what?
Well, one of the most critical is that NASH is now the fastest growing cause of hepatocellular carcinoma worldwide. That's a common type of liver cancer.
Right.
And notably in the United States, it's also the fastest growing reason or indication for needing a liver transplant.
So it's driving up the need for transplants.
Exactly. Now, while only a minority of NAFLD patients, maybe 15–20%, progress to NASH, and of those, maybe only 10–20% will actually develop cirrhosis that's severe scarring. The sheer volume of initial NAFLD cases means a significant number of people are still ending up at high risk. And we see big geographic variations, too. Prevalence over 40% in places like the Americas and Southeast Asia.
So NAFLD is surging, creating more patients needing transplants. But here's the really tricky part, the twist. This epidemic isn't just increasing demand, it's shrinking the supply of organs at the same time.
Yeah.
It's a real double-edged sword. Let's talk about the donor pool.
That's exactly right. The ripple effect is profound because the rise in NAFLD in the general population means a high prevalence of fatty changes in potential liver donors themselves.
Oh.
Studies report that a significant chunk, somewhere between 15 and 53% of potential living donors actually have biopsy-proven NAFLD.
Living donors too, wow.
Yes, and this has a severe impact on organ availability overall. Between 3 and 21% of intended liver grafts from deceased donors are discarded specifically because of steatosis, because of fat in the liver.
Completely.
Discarded, can't be used. And predictive models, these are worrying. They suggest that by 2030, if current obesity and diabetes trends continue, only about 44% of offered grafts might actually be used.
Only 44%.
Down from around 78% back in 2010.
That's nearly half.
Think about that. Potentially half as many organs available for life-saving transplants in just a few years. Yeah. It's a silent crisis unfolding, really threatening the donor pool.
That's a staggering potential drop. So, okay, a potential donor liver becomes available. How do doctors even figure out if it's too fatty? It sounds like a critical decision with huge consequences.
It is, and it's complex. The gold standard, the ideal scenario, is histology, a biopsy of the liver tissue.
Right.
But our sources indicate this is only done universally in about 23% of deceased donors in the U.S. system, UNOS.
Only about a quarter. Why so low?
Time, resources, logistics, and a time-sensitive situation, and just looking at it or feeling it, visual inspection and palpation by a surgeon. Surprisingly, notoriously inaccurate for fat. Less than 20% positive predictive value for even mild steatosis.
So you can't just eyeball it?
Not reliably, no. So non-invasive tools become crucial. Doctors have a range of tools, kind of like different lenses to view these potential donor livers. Each has strengths, but also blind spots.
What are they using then?
Well, ultrasound is widely available, but its sensitivity is poor for less than, say, 20 to 30% fat. It misses milder cases.
Oh.
CT scanning, using a liver-spleen ratio, that's more reliable. One study showed pretty good sensitivity, 79%, and specificity, 97%, for picking up 30% or more steatosis.
Bitter, but
But it can't distinguish between micro and macrovesicular fat, and that distinction turns out to be important for risk. Then you have more advanced tools like MRI-PDFF or MMR spectroscopy, very accurate for quantifying fat.
the best.
Accuracy-wise, yes, but often impractical for deceased donors. Time, cost, availability in an emergency setting. It's tough.
Makes sense.
A really promising option is transient elastography. Specifically, its controlled attenuation parameter, or CIP score. This is basically a point-of-care ultrasound measure.
Something they can do quickly.
Exactly. Good accuracy for detecting any steatosis. The AC is around 0.86 to 0.89, so it's quite reliable. It's inexpensive, no radiation, makes it a useful screening tool.
But still not perfect.
No single test is perfect. And even a biopsy can miss fat if it's patchy, not evenly spread out. Heterogeneous fat is a known issue.
So given these tools and challenges, how do transplant teams make the call? Which livers are too fatty? What are these critical steatosis thresholds?
Right. So histologically, when they do get a biopsy, fat is classified. Mild is less than 30% macrovesicular steatosis, those big fat droplets.
Okay, 30% mild.
Moderate is 30 to 60%, and severe is over 60%.
Got it.
The consensus generally is that mild macrosteatosis under 30% is safe. Grafts with this level tend to have outcomes comparable to non-fatty grafts.
So those get used.
Those are often used, routinely in many centers. At the other end, severe steatosis over 60%. Almost always a no-go, a contraindication.
Why?
It's because the rates of primary non-function, the liver just not working at all, and early graft failure are extremely high, so those are almost always discarded.
Makes sense. And the middle.
That's the gray zone. Moderate steatosis, 30 to 60%. Some centers will use these, but very cautiously. They try hard to minimize other risks, especially ischemia time, the time the organ is without blood flow.
How much does that matter?
A lot. For example, one study found that even 20 to 30% macrosteatosis, technically mild to moderate, if combined with over 11 hours of cold ischemia, significantly predicted graft loss.
Wow. So the fat makes it more sensitive to that cold time.
Exactly. And crucially, it's the macrovesicular fat, those large droplets, that really drives the risk. Microvesicular steatosis, smaller droplets, doesn't seem to impair outcomes nearly as much, if at all.
Yeah, that's a key distinction. So putting this together, what's the impact on how these fatty livers actually perform after transplant? What challenges do they pose immediately?
Well, steatotic grafts suffer more ischemia-reperfusion injury. That's the damage when blood flow returns after being cut off. Fatty livers are just more vulnerable. And this translates into higher rates of primary non-function, as I mentioned, but also delayed graft function where the liver is slow to wake up.
Takes longer to start working properly.
Right. Also, more ischemic biliary complications, problems with the bile ducts, higher rates of kidney failure, longer hospital stays. Basically, early graft quality and function can be compromised.
And are there other factors that make it even worse if you have a fatty graft?
Yes, definitely. Multiple factors can compound the risk. Things like older donor age, prolonged cold ischemia time, getting a liver from a DCD donation after circulatory death,
Okay.
donor diabetes, and even recipient factors like the recipient having a high BMI or if NASH was their original reason for the transplant. All these can worsen outcomes with a fatty graft.
That sounds like a lot stacked against these grafts. Is there any hope for using them successfully? Or are we just looking at fewer successful transplants?
Well, despite these challenges, there's a glimmer of hope. Overall graft survival with marginally steatotic grafts, say, in that mild to maybe lower moderate range, can still be acceptable with really careful management.
Now, what could they do?
Strategies like aggressively minimizing cold ischemia time, keeping it under 6 hours if possible,
Yep.
using techniques like in situ perfusion before retrieving the organ, or even machine perfusion.
Machine perfusion, like keeping it on a pump.
Exactly. Sometimes it's even called defatting perfusion, though the evidence for actually removing fat is still developing, but it can help assess the liver and maybe mitigate some injury.
Interesting.
So, to summarize the donor dilemma, mild steatosis, 30%, is generally used routinely with good outcomes. Moderate, 30 to 60%, is used selectively, very cautiously. And severe, 60%, is typically avoided entirely.
Okay, that makes sense. Now, let's shift focus to the other side of this coin, the recipient's journey. What happens to patients who get a liver transplant, especially if they had NASH to begin with, or if they develop fatty liver after the transplant in their new organ? This whole idea of recurrence versus de novo, NAFLD NASH.
Yeah, this is a really significant ongoing challenge post-transplant. The figures are quite striking. For patients transplanted specifically for NASH,
The ones who already had it badly.
exactly, somewhere between 30 and 60% of them experience recurrent steatosis. Basically, NAFLD coming back in the new liver within about 1 to 5 years.
Up to 60%.
It's common. Now, for those transplanted for other reasons, say viral hepatitis or alcohol-related disease,
Okay.
endo-novo NAFLD, meaning it develops for the first time in the new liver, occurs in about 20 to 30% of them.
So even if they didn't have it before transplant.
They can get it afterwards. So overall, roughly 2 out of every 5 liver transplant recipients eventually show some fatty infiltration in their graft.
2 out of 5. That's a
Yeah.
lot. Is it usually serious?
Well, it's important to note that most post-transplant NAFLD is mild steatosis. Progression to actual NASH with inflammation and injury, or to advanced fibrosis, is less common.
Okay, that's somewhat reassuring.
It is. Recurrent NASH happens in maybe 10 to 33% of those originally transplanted for NASH. De novo NASH is seen in maybe 5 to 10% of the others. But one thing we do see is that recurrent NAFLD often appears earlier and can sometimes be more aggressive than de novo.
Interesting. So what drives this? What are the strongest predictors for getting NAFL or NASH again in that new liver? Why are these factors so impactful?
The absolute strongest predictors are the recipient's metabolic health after the transplant, specifically metabolic syndrome and significant weight gain.
So the same things that cause it in the first place.
Pretty much, yes. Think about it. The underlying lifestyle factors, the metabolic environment that led to liver disease initially, often persist or can even get worse after transplant.
Why worse?
Well, other risk factors include recipient obesity, diabetes, high triglycerides, and crucially, exposure to certain immunosuppressant drugs needed to prevent rejection.
Ah, the medications themselves.
Yes, steroids and calcineurin inhibitors like tacrolimus are notorious. They substantially increase the risk of metabolic complications, weight gain, diabetes, high blood pressure, high cholesterol.
So the drugs need to keep the liver.
Can contribute to making it fatty again or cause other metabolic problems. It's a difficult balance. One meta-analysis found that obesity after transplant carried about 4.6 times higher odds of getting steatosis in the graft. Metabolic syndrome, about 3.3 times higher odds.
Huge risk factors.
Absolutely. And while having NASH before the transplant is the strongest predictor of getting steatohepatitis, NASH again, the recipient's overall metabolic health post-transplant seems to be the main driver in the long run, generally more important than factors related to the donor liver itself.
Okay, so someone develops NAFLD or even NASH in their new liver. Does that mean the transplant basically failed? Is the graft going to fail prematurely?
Right.
That sounds terrifying for a patient.
It's a critical question, and it's important to be clear here. Based on most studies, post-transplant NAFLD or NASH does not seem to drastically shorten the life of the graft itself.
Oh, really?
Yes. Patients with graft steatosis haven't shown significantly higher rates of progressing to cirrhosis in the graft, or higher overall mortality compared to recipients without steatosis, at least in the long-term data we have so far, which is still somewhat limited.
Okay.
Overall, survival rates at 1, 3, and 5 years after a liver transplant for NASH are generally comparable to transplants done for other reasons.
So the liver itself usually keeps working.
Broadly speaking, yes. NAFLD or NASH recurring in the graft is generally not an independent killer of the liver in the post-transplant period.
Okay, that's a huge relief regarding the graft itself. But if the graft isn't failing, what is the main worry for these recipients then? Where's the real long-term danger?
This is the crucial point, and it represents a major shift in how we think about outcomes for these patients. The danger lies in the serious metabolic and cardiovascular complications.
Ah, the systemic effects.
Exactly. Transplant recipients commonly gain weight. The average is about 5 kilos, maybe 11 pounds, by 1 year, and 10 kilos, or 22 pounds, by 3 years post-transplant. Over half become overweight or obese.
Why so much weight gain? Lifestyle, medications.
Both. And the immunosuppressants definitely exacerbate it. Steroids and tacrolimus, as we said, promote diabetes and weight gain. Other drugs like CNIs and mTOR inhibitors can worsen hypertension and dyslipidemia.
So it's a perfect storm for metabolic problems.
It really is. Post-transplant metabolic syndrome becomes very frequent. One cohort showed diabetes developing in 40 to 50% of patients after transplant, new hypertension or dyslipidemia in 30 to 40%.
That's incredibly common.
And this translates directly into high cardiovascular risk. This is now a leading cause of morbidity and mortality after liver transplant for patients who had NAFLD NASH.
More than liver problem.
Yes, for this specific group, the numbers are stark. One study showed up to 11% of NASH liver transplant recipients died of cardiovascular causes within just 1 year.
11% in 1 year.
Other reports note cardiac events happening in 10% by 1 year and 30% by 8 years post-transplant. Infections are also a common cause of death, likely linked to immunosuppression and metabolic issues like diabetes.
So the main threats aren't rejection or the liver failing again.
For the NASH population, cause-specific mortality is dominated by non-liver issues, cardiovascular events and infections, not recurrent liver failure. While maybe 2/3 of NASH recipients develop some fibrosis, like F1, in the graft by 5-10 years.
Okay.
Only a very small fraction, maybe 2 to 3%, actually progress all the way to cirrhosis or need a retransplant because of NAFLD-related failure.
So the focus really has to shift after the transplant.
Completely. For NIR patients, a successful liver transplant isn't the end of the story. It's the start of a lifelong battle against heart disease, diabetes, stroke, and other metabolic issues. You win on the liver front only to face these other critical health challenges.
Okay, let's try and summarize this deep dive then. The NAFLD NASH epidemic, it's hitting liver transplantation from two sides, creating this twofold challenge.
Exactly.
One, it's threatening the donor supply, making more potential donor livers unsuitable, leading to more discards.
Right. Shrinking the pool.
Right. And two, it's creating this large, high-risk group of recipients who are prone to serious metabolic complications, and also the recurrence of fatty liver in their new graft.
That sums it up perfectly, and managing this really requires a multi-pronged approach. On the donor side, it means being smart about using those mildly fatty grafts, ideally 8-30% macrosteatosis.
Using them when possible.
Yes. Combined with careful evaluation, maybe using advanced imaging like CAP or CT more routinely, and potentially using machine perfusion to assess or even improve some of those marginal higher fat grafts we might otherwise discard.
Okay. And for the recipient?
Post-transplant, aggressive control of weight and all those cardiometabolic risk factors is absolutely essential. It's not just about preventing the graft from getting fatty again, although that's part of it.
It's about the heart.
It's primarily about mitigating that very real, very significant risk of cardiovascular events, heart attacks, strokes. While long-term graft function is generally maintained, vigilant, lifelong management of metabolic risk is paramount for optimizing the patient's overall outcome, making sure that transplant leads to a longer, healthier life.
So thinking about all this, what does it really mean for you, our listener? Consider this. The very lifestyle factors driving the global NAFLD epidemic are, at the same time, shrinking the donor pool and creating these major new health challenges for recipients after transplants. What does that imply for our public health strategies, both locally and globally? How do we stem this rising tide to ensure these life-saving treatments remain viable for everyone who needs them? What really stood out to you in this deep dive? Thank you for joining us on this deep dive. Stay curious and keep learning.